Dr. Miyasaki is currently the director of the Parkinson and Movement Disorders program at the University of Alberta and is the co-director of the Neuropalliative and Advanced Symptom Management Clinic. She initiated the first neurologist-led palliative care movement or palliative care for movement disorders in the world, and will be sharing her knowledge with us today. So welcome, Dr. Miyasaki, and thank you so much for being here.
Thank you. And again, apologies for the delay. I am going to share my slides now. There we go. And move this over. And get a slideshow. There we go. So today we're going to talk about advanced care planning and why everyone over the age of 18 should have advanced care planning done. These are my disclosures. So we're going to go over what is advanced care planning, what are the other terms for advanced care planning, some useful sites, and some useful scripts actually for you to prompt your family doctor or your neurologist to help you with this. So you may be familiar with the concept of palliative care as being mostly focused on the end of life. But in fact, palliative care is now taken to encompass more of that because it was always meant to address the symptoms that of incurable conditions. And if you think about it, there are very few things in medicine that are cured. So really, a palliative approach can help in multiple conditions, including Parkinson's disease. And why is that? Because it looks to optimize quality of life, maximize community supports, to use early symptom management, and to help people participate in advanced care planning. So this is a slide I actually show physicians clearly. It's about why people overestimate the benefit of ICU admissions. And why are patients going to their lawyers to complete advanced directive forms instead of going to their physicians? Well, the reason why we overestimate the benefit of an intensive care unit stay is television, media, because that's where a lot of us get our information unless we've had a personal experience with family members who have been in the ICU. So where else are you going to draw from? From the media. And so when they looked at, this really dates me because I watched all these shows, Chicago Hope, ER, and Rescue 911 in 94 to 95. They found 60 occurrences of out-of-hospital cardiac arrest requiring CPR, and 75% of people survived to discharge. And at least, 75% survived the cardiac arrest, and 68% were shown leaving the hospital in their previous state. But realistically, the survival rate for out-of-hospital cardiac arrest was about 10 to 15% until they started putting defibrillators in the public and at sporting events and sporting venues, because the easiest cardiac arrest to survive or to help is someone who has an irregular heartbeat or has a cardiac arrhythmia, and then the defibrillator stops it. So now it's gone up to 20%. So out of hospital cardiac arrest, the survival rate is 20%. So that's vastly different from what the impression is that you're getting in television. And what is advanced care planning? Because there's a lot of terms that go around, especially in this province, because we have the goals of care sheet, and then we have advanced care planning. And these are two different things. Advanced care planning is a process that supports adults at any stage or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care. The goal of advanced care planning is to help ensure that people receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. And so you can see from that, it's a very broad thing. It's not just a letter and a number. It is something deeper about what to you is a good quality life, what to you would be an acceptable risk in order to have more time, and how much suffering would you be willing to undertake in order to potentially have more time. So physician orders for life-sustaining therapies is not the same. That's present in a lot of American and some Canadian provinces. And it's not what colloquially people know as the do not resuscitate order. That is not advanced care planning. Advanced care planning, just like the word says, happens before the event requiring a decision. And it's also not the same as shared medical decision-making where there's a back and forth. The ACP is actually you stating what your values are and what you would find acceptable. So this is a bit blurry, but this gives you an idea of our goals of care form. This is the legally recognized form in Alberta for goals of care. And it was started in Calgary and then has expanded to the rest of the province. And it has definitions for what each level would entail. And so the R level is really going to an intensive care unit would be acceptable and likely to benefit the person. So the other thing to keep in mind is when you fill out this goals of care form, you may say, R1, I want absolutely everything done. But the intensive care unit doctor, when on the day that you unfortunately might have to go to the ICU, might say, this person is not likely to benefit from an ICU stay. That is to survive and leave hospital. And they may elect not to admit you to the ICU. And that is the right of the physician to do so because they do not have to give you treatments that they think will cause you harm without any possible benefit. The next level is the medical level of treatment. So this means in general that you would, for M1, go be taken to a hospital in order to receive care that would relieve your symptoms and possibly prolong life. M2 means that it could occur in a non-hospital setting. So this is most relevant for people who are in a designated assisted living or long-term care. So they could receive care in place, but they do not want to be transported to a hospital. And a lot of care can be given in these settings. And finally, the C level of care, which is comfort care, when the goal of treatment is not to prolong life, but only to relieve symptoms. So this gives you sort of in broad strokes what our goals of care designations are. And just to remind you again, is that process to articulate your values, life goals, and preferences. So let's broaden it to what those things are and some tools that can help you. So in general, when you're having an advanced care planning document, sharing it with your family is very important. It's also important that your family is on the same page as you about where your health is and what is the outlook for you. And I always tell patients that advanced care planning is like your evening clothes. You should take it out once a year to make sure it still fits. So Declan is young. Declan will want to have everything, presumably. I am now 58, so I may say, you know, I'm willing to give the ICU a try. But if things are going badly, I would like that to be revisited with my family. Whereas someone who's in their 70s or 80s might have a different idea of what they are willing to undertake. Sorry, my computer, the setup, my computer is actually obstructing my thing, so I can't see. So it should focus on overall goals of medical care. And you may also want to identify a trusted person who can help make decisions on your behalf. So that's in Alberta is called a personal directive, and other places is called power of attorney medical. And I would contend that when you are thinking about your advanced care planning, that you discuss it with a trusted healthcare provider. So either your family doctor or your neurologist, in order to see where they think you are and what they think are possible outcomes for burdensome interventions like the intensive care unit. I think that all of us have read articles because of COVID and because so many more people are experiencing the ICU setting, that is actually traumatic, that many people leave neurologically altered, who didn't have neurology problems before, significantly weaker, and many have written poignantly about the post-traumatic stress that they have experienced as a result of the ICU stay. We often don't think about that. And an ICU stay is like going to battle, and whether you want to undertake that. The discussion should be recorded in writing, and it should be available. So if you have a great advanced care planning discussion with your doctor and your family, and it's recorded, but it's in a filing cabinet where nobody knows where it is, it's not helpful. So having it in a place where people know how to access it is really important. And to give you an idea of just going over goals of care, this is the algorithm that Alberta Health Services suggests we follow to have a goals of care discussion. It's like so complicated, it's mind-boggling. And the reason why we encourage people to do advanced care planning earlier is because in Parkinson's disease, even though people don't fulfill the definition of having dementia or problems with memory and thinking, 20 to 50 participants who said, you know, I'm just not as sharp as I used to be. That's a pretty low bar, right? Many of us could say that. I'm just not as sharp as I used to be 5 years ago. But 20 out of 50 of them had impaired decision-making despite having normal cognition. And so that's why if you leave it until someone is in their last year of life, you're likely to have missed the opportunity to have real meaningful discussions about what their values are. And the other barrier to having both advanced care planning and goals of care designations properly done is that the reading level for the documents across Canada are generally exceeding what is the recommended reading level for people. So you can see in Alberta, ours is pretty complicated. It requires a grade 12 education in order to understand the goals of care. Now, this is a different way of approaching advanced care planning, which I quite like. And this is a website that you can go to, and you can use the electronic resource free. And it's about choosing things that are important and of value to you if you are ill, and what is important to you in terms of decision making. And so when you go to this this slide, you can go to the resources and it'll come up electronically. And what you do is choose very important, somewhat important, and not important. And you take cards that have different aspects of care and decision-making, and you file it in either very important, somewhat important, or not important. And you have to get through the whole deck. So you start rejuggling things and putting things in different orders. And you'll see that it actually does provide a little bit of a framework for people to understand and help with decisions if you can't make decisions. So one of the questions is, pain relief is very important to me, and pain relief is not important to me. So there are some people who would not want to experience pain, even if they were less mentally clear as a result of the medications. And then there are other people who say, you know, I don't like pain medications. They make me feel kind of weird. I would prefer to have less complete pain relief in order to be mentally clear. So it gives you that opportunity to at least think about it ahead of time. You can always change your mind, but it brings up different aspects of care that I think we often don't think about. Yeah, one of the nice ones that I like is, I would like people to hold my hand. During COVID, we were told not to touch our patients. It was horrible. So to articulate that, I'd like someone to hold my hand. I'd like the nurse to hold my hand when I'm having a procedure done. You know, that tells us something that you would like reflected in your care. So this is a very brief overview about advanced care planning versus goals of care. I think that everyone over the age of 18 who has decisional capacity should have both documents. And I think that these are at least some tools that can help you with your advanced care planning. So I'll stop it there so that there's plenty of time for questions. And I am just going to go to the chat because I see there's lots of questions. Oh, why is my chat not showing up?
Well, I can read them out if that's easiest.
Okay, sure, Declan.
Okay, perfect. So I have someone asking quickly. So this will be available later on our YouTube channel, and then for anybody who would like to submit questions, you're able to do so in the chat. You can type out to everybody or to just us, the panelists, if you prefer to remain anonymous there. And well, why don't to start off with, I had a question about cognition. So at what point does it become too difficult for someone to sort of fully complete a goals of care designation if their cognition is impaired?
Yeah, so that's a difficult question because it varies person to person and also incident to incident. So goals of care is an overall designation, and it's pretty complex because you saw there it was talking about chest compressions are okay, ventilation is okay, this is okay, that's okay, but this is not okay. It is hard to keep track of all that information and come up with a decision, right? So when people are starting to have problems grasping multiple pieces of information to come up with a final decision, they probably are going to have challenges with the goals of care. This is different from capacity, right? Because capacity to make a decision can be present even when someone has moderate dementia. Because you can say to them, you know, Declan, you're having problems breathing and you have a fever. I think you have pneumonia. If I give you an antibiotic, that will help you breathe easier. Your fever will go down and you'll feel better. Is that okay if we do that? You probably, even in a very moderately demented stage, could say, yeah, I want that. So capacity is different from ability to make a goals of care decision, because you may be capable of making medical decisions, but not capable of doing the goals of care anymore. Oh, Declan,
sorry about that. Yeah, great. Thank you for answering that. Still waiting on some questions to come in. So everybody, if you would like to type out your questions in the chat below, you can. I guess second one for me, and maybe it was addressed in the presentation, I missed it, but what is the first step to getting started? How would, what is that step?
So in Alberta, they make it very easy. If you type in goals of care or green sleeve. Our program is known as the green sleeve because they put it in a green plastic thing, although government cutbacks may take away the green plastic sleeve. And the reason why is, yeah, actually I haven't seen any green plastic sleeves lately, so they probably have already. But it's two sheets, one sheet, which has the designation on it, and the other sheet has, which I quite like, but isn't often used, is a list of who was present in the conversation. So I put down all the patient and the family members that were present. I put down every healthcare provider that was present. And then I put down what we discussed. So what information I gave and what information came back from the patient and family about what they value. And when both sheets are present, I have to say that I've actually had calls back from the ICU doctors saying that was so helpful, what you recorded down in the green sleeve. Like that was even more important because I could say, you know, when you talked about this and you said this, I want to respond to that. So that was very helpful for them. And I think it's helpful for the patients and families to have, you know, thought about it and had a chance to talk about it with a physician or nurse practitioner they trust.
Great, thank you. Excuse me. One question coming from the chat here. So I think this is expanding on the what you were talking about earlier about cognition. Does a person who's already experiencing cognitive issues need to be certified by doctors that they are cognitively capable to make the advanced care planning document?
No, you don't have to be certified in order to make the goals of care document, but when it's properly done, the physician who's recording it or nurse practitioner who's recording it should have elicited that the patient understands what the interventions are, what the potential benefits are, what the potential risks are, and alternatives to the proposed treatments. And they need to reflect back in a way that shows that they have reasoned against prior experience and prior knowledge and their prior values in order to articulate a choice. I would have to say most physicians don't do that. Because I had to do the research in it, I had to read all about this and I was like, ooh, this is way more than I ever did. So now I conduct my goals of care discussions differently to ensure that people understand all these things and that they actually are capable of making the decision. And that's the other reason why writing the narrative is probably even more important than the letter and the number, because the narrative should reflect what the patient has said in response to the information to demonstrate that capacity to understand.
Great, thank you. This question comes in. Please explain again what the differences are between personal directive and ACP. We went to a lawyer's office to set up the personal directive. I assume that's not required for ACP.
Yeah, so a personal directive in Alberta has a very specific connotation. It means the person to whom you designate the authority to make decisions on your behalf, should you be incapable of making decisions. And and the lawyer will usually have you outline the first person, second, third, sometimes it goes down to fourth or fifth, right? Because if say you're a person and you have some adult children, but you tend to vacation together, you can't actually make your adult children the next people in line, which normally it would be. You would probably have to go beyond that because you tend to travel together. So if you're in a catastrophic accident on holiday, you would need another individual to make that decision. However, even if you don't have a personal directive, the authority is spouse, then adult children, then parents, then adult siblings, and then it goes down further from there. So there is an actual default in case, as most people have not done their personal directive, there is a legal default of who it should be in order. It does become difficult as people are separating, getting divorced, and they haven't updated their information, and it still labels their ex-spouse. That is always very difficult because the paperwork says the ex-spouse, but in reality, the spirit may be more that it is a sibling who would be better placed to be the personal directive. So it's important to make sure your personal directive is updated.
Yeah.
And then the other question to that was, what is the difference between personal directive and ACP? And so the ACP is, as I said, an advanced care planning document. It does not have the same legal weight as the goals of care document, which is signed by the physician, but it would be used to guide decision-making and can be helpful for your personal directive designate to look at and say, oh, they've said here, life at all costs would be meaningful to them, even if they don't recognize and they can't interact with family. That's what they would value. Or it might say the opposite. They've actually said they would only value life if they could recognize their family, or if they could interact with their family, or if they could live independently. Those are the only outcomes that they would want. And then that can help guide decision-making.
Thank you for that clarification there. This question comes in, what if a person wants to donate their body to research? Where should this be documented? Should it be documented in the presence of a doctor? Does it have to do with any of those documents we just discussed? Where would that fall?
So donating your body to research may be helpful if you have a specific condition and you want to donate it to a group that has an established brain bank program, because we're talking about neurology conditions. And then you would fill that paperwork out with the group that would receive the organ, because there's a lot of things that go into brain donation. So I was involved in that at the University of Toronto. We had to pay a nurse to be on call 24 hours a day, 7 days a week to receive pages for this. We had a fund set up to pay for transportation to the hospital, to pay for the autopsy to extract the brain, and then to pay for the fixing and shipping and storage of the brain. We would save half the brain at the University of Toronto, and we would send the other half of the brain to a research consortium in the United States that we participated with. So that was all set up ahead of time so that the costs were undertaken by the program. If you pass away at home, the likelihood is that you will not be able to donate your brain. Because of the logistics required, it requires an ambulance to a hospital where a pathologist is willing to take out the brain, fix it, and then ship the brain to whatever facility is desired. And the costs are not inconsiderable. So it requires a lot of doing. And in general, research institutes have not been keen to have brain bank programs because they are expensive, and because what they see as a positive outcome, a research institute sees as a positive outcome, papers, patents, and more grants. And when you start a brain bank program, it will take a minimum of 10 years for you to start seeing any product from that. So research institutes in general are getting less keen to fund it. And I would say our hospital foundation said that is a no-go topic because we've talked about it several times to them. They have said nobody wants to fund that. No donor wants to fund it. You have to get the money elsewhere. So we are not currently doing that. There are brain bank programs, I think, in the Prion Institute, which is a different condition that is for Jakob-Creutzfeldt disease and other conditions. And we have a smaller, we are starting a smaller brain bank program for amyotrophic lateral sclerosis. And that is in conjunction with a larger grant. And that's probably because as compared to Parkinson's, where there are at any one point in time between 10 and 12,000 Albertans who have Parkinson's, for ALS, the number is 64. So 64 to about 120 people in Alberta would have ALS, compared to the thousands and thousands of people who have Parkinson's.
Yeah, thank you for that in-depth answer there. I think a lot of our clients often think about this, contemplate donating their body to research, but sometimes they would think it would be a simpler process than what is really involved in that. So yeah, thank you for answering that. Kind of going back to that previous question there, talking about family involvement. Do you have any advice for clients wanting to navigate this conversation with family, especially if their family might want them to pick the option where they take the most amount of interventions, or they want to keep them alive as long as possible, and that may not be the wishes of the individual?
In those cases, especially, it is important to have the conversation, because if you can't make the decisions and you have not documented anything, then the default is to ask your relatives. And you want to have your wishes respected. It is hard to have these discussions sometimes. One patient, I remember, she sat down and her son was there and she said, I want to talk about do not resuscitate order, because in Ontario, that's what we had. We don't have all these grades. And so I said, okay, let's talk about that. And the son said, she doesn't want to talk about that. You can't talk about that. And I said, well, she just said that. She wants to talk about it. And he said, she doesn't. Stop talking about it. And I said, this is her appointment. You're here, and that's really awesome. But she wants to talk about it. So we're going to talk about it. And he stood in the corner with his arms crossed the whole time. But his mom really wanted to talk about it. So that was one way she made me the bad guy. And that's okay, because I was happy to advocate for her to have her voice. I thought that was important. There's another good one that's called 5 Wishes. That does require a cost, because they charge you to download their booklet to fill it out. But it does have a way to sort of start off the conversation with family members, and an approach to complete a form about what are your 5 wishes, which are generally about who you want to make decisions, how you want information shared, how you like to get information, etc. And people complete it, and then they photocopy it, and they give it to their adult children, as is often the case, and they say, these are my wishes. I know that one person, they describe her story on the website. The kids didn't want to talk about it. So at Thanksgiving, she put the booklet on all their dinner plates and said, you have to read it before I'll give you dinner. And so that was her way of getting across what her 5 wishes were.
Yeah, thank you for answering that. We have one more question coming in here. I recall that there are instructions in the personal directive regarding what to do in medical situations. If these instructions happen to not be in line with the ACP documents, does the personal directive take precedence because it's a legally binding document? Or how does that interaction of documents work? Or is this too much into the weeds?
Yeah, that's into the legal weeds.
Mm-hmm.
I would say they should be congruent, right? Like they should be, they should pretty much match. And that's why having a lawyer do it is kind of weird to me, because the lawyer doesn't understand medical things. They understand legal things. And so the other way to get around that is to say the personal directive shall refer to the most recent ACP completed by the named person. And that way you can have your most recent document put, available to your personal directives. So that's another way around it. But I would say that it should be, because some lawyers is very, very, I've seen what the lawyers have printed in, and I'm like, and the people bring me this paperwork, I'm like, this doesn't help me with the decision at hand. It doesn't help you with the decision at hand, more importantly, right? Because the whole goal of the advanced care planning document is to help your family feel secure that they have made choices that are congruent with your values when you can no longer articulate them. And for any of you who have experienced it in hospital, you know that it's just so difficult for families to feel secure unless they've had those conversations. And I'm frequently asked, am I doing the right thing? Am I doing the right thing? And, my heart breaks for these families. And so you can think of your ACP planning as an opportunity to save your family this distress.
Yeah, that's a great way to put it. And I don't see any more questions here. We do have one or two more. We've got about 5 more minutes here. I will maybe I'll do my wrap up, and if any other questions come in, then we can address them quickly right at the end. So I just want to ask,
you know what, you can put up your hand because you have the raise hand option.
Mm-hmm.
How many of you have your own ACPs done? I do. I'll put up my hand.
We got 1, we got 2, 3.
So for the goals of care discussion, no, that's billed to Alberta Health Services. And you should though give a sort of warning to your doctor, because it requires more time, and say that I would like to discuss my goals of care designation. And some of the family doctors are really great at it. If they're uncomfortable with it, yeah, that's an issue, because it should be your family doctor who is most comfortable with it. And then if you want to have the discussion with your neurologist is hopefully comfortable with it. But again, sometimes I start off the conversation and I give the paperwork to the patient for them to read and review and discuss with their family, and then they complete it with their family doctor. And that has worked very well too.
Yeah, great. Okay, well, I think we will wrap things up there. I want to thank you so much for coming out and speaking, Dr. Miyasaki. And again, I want to apologize for the technical difficulties that we had starting at the beginning here.
Well, there's a last question. What happens if the person has already lost the cognition to do ACP? That is a problem, because then they cannot do it, right? Because if you think about it, you're articulating what would be a good quality of life to me. And if you think about it as you're sitting now, you probably have a very clear idea of what you want. But you may not be able to think of all the contingencies. If someone has already lost the cognitive capacity to do the ACP, then you can't have the ACP. And then their personal directive will now have to take on the role of that. So the ACP work, which one? The goals of care, the green sleeve? Can the person who just typed that question follow up? Is that the green sleeve you mean, or was it the Go Wish and 5 Wishes? ACP. So the ACP, those are the 5 wishes. 5 wishes and Go Wish. You can just go on the website. So you just type in Go Wish. And it should take you to that website. And then for 5 Wishes, that's a very famous program. You just type in 5 Wishes and it will take you to this nice website that will explain how to get the forms to fill it out. If it's the goals of care for Alberta, you just go to Alberta Health Services and you just put in goals of care, and they will do it. The cognition problem, yes, still with ACP, with the 5 Wishes, even if someone is very cognitively impaired, they usually can say who they would want to make choices on their behalf. But some of the other things, they may struggle with the concept. And so it depends, because of course, that's a whole spectrum, right? Some people have a little cognitive impairment. They aren't quite as sharp, but they can do a lot of reasoning. And other people have a lot more of the reasoning issues. And so, yeah, I think that's why it's important to be brave and have these conversations earlier. And that's why if any of you are the care partners and you didn't put up your hand that you have your own planning done, I think you should do your planning. That's why I did my planning. One, because I'd be embarrassed if I gave these talks and I hadn't done my own planning. And I dragged my husband, who's a lawyer and superstitious. I made him do his plan because he said, if I talk about it, it'll happen. And I said, no, that's not how it works. Talking about death doesn't make it happen. But if you don't plan, then I might make, that might be a marriage-breaking talk, yes. But if we don't talk about it, maybe I'll make the wrong choice for you. I don't want to. So, so he and I can proudly say we have everything in place and we've done everything. But I'll tell you, when I give this talk to doctors, there's usually only 4 other doctors who can put up their hand honestly in the whole group. So it's not just you, it's doctors, it's everyone has this aversion to doing it. And yet when you do it, it'll be a weight off your shoulders. You'll feel relief. And your family will so much appreciate it if, God forbid, you end up in hospital.